So dear course audience, today's topic is a very, very important topic, most practical point. And we see a lot of the cases of rheumatoid arthritis in our daily practice. It's a very troublesome disease, very big disease, a disease with a lot of the morbidity and the mortality. So with these few outlines, we'll go to the topic proper. So whenever you see a case of the arthritis, there are a lot of the cases are there, a lot of the diagnoses are there, like osteoarthritis or RA or gouty arthritis, psoriatic arthritis, a lupus, septic arthritis or systemic sclerosis or ankylosing spondylitis, etc., pseudo gout, okay, or polymyalgia rheumatica, etc. So it's not that easy to diagnose the rheumatoid arthritis in the initial days of the presentation. But if you are a good clinician, and definitely you can suspect the rheumatoid arthritis and you can diagnose the rheumatoid arthritis in the early days so that you can treat this disease very effectively. So this is the commonest inflammatory joint disease seen in the clinical practice, approximately 1% of the population. So imagine 140 crores of the Indians and 1% of the population is very big disease. It's a chronic disease. It's a multisystemic disease. Still the exact cause is not known, mostly the idiopathic, maybe an interaction between the genes and the environment. It is characterized by the persistent inflammatory synovitis. So it's all inflammatory. Last class we discussed about the inflammatory arthritis and non-inflammatory arthritis. So morning stiffness. Okay, so these are all the features of the inflammatory arthritis. And left untreated, it leads to the cartilage damage, the bony erosions, joint deformity, disability, and also early death. So it can occur at any age group, but mostly it is in the 3rd and the 6th decades. Female and the male ratio is 3:1. So unfortunately, most of these autoimmune diseases are more common in the female, except ankylosing spondylitis, which is more common in the males. Psoriatic arthritis equally. Initial pattern of the joint involvement could be a polyarticular or oligoarticular or monoarticular. So sometimes it may present as a monoarthritis, and later 2 to 4 joints, that is oligoarthritis, and then the 5 or the more than the 5 joints, that is the polyarthritis. Morning stiffness usually more than the 1 hour. Some people will have 2 hours, 3 hours, 4 hours also. And easing with the physical activity is a characteristic. So they feel comfortable on the routine daily activity, and if they get more painfuls when they take rest. So the rest pains are there, nocturnal pains are there, morning stiffness is there, and small joints of the hand and the feet are typically involved. So the most common joints involved here are the proximal interphalangeal joints, metacarpophalangeal joints, wrist joints, etc. So already I told all these points, women and male, the 3:1 at any age group. Peak onset is between 30 and the 55 years of the age group. See the prevalence. So India, no way inferior to Australia or US or the Europe. So still we have a lot of the rheumatoid arthritis patients in our pocket. So what is important in the rheumatoid arthritis is 40 to 60% they present with advanced rheumatoid arthritis. So because of the poor awareness, because of the poor diagnosis with rheumatoid arthritis, nearly 40 to 60% of these people they present with advanced rheumatoid arthritis with a lot of the disability, dysarthrias, etc. They survive 5 years or less following the diagnosis. So survival rate is also reduced if you delay the diagnosis. They die 10 to 15 years earlier than the expected. So that is the most piteous point in rheumatoid arthritis, late diagnosis. So nearly 10 to 15 years early they die when compared to the normal population. Damage occurs early in the most cases. 50% show the joint space narrowing or erosions in the first 2 years. In the first 2 years itself, the joints shows narrowing and the erosions. But it is very difficult to diagnose in the first 2 years. So a lot of these people, they have the mild morning stiffness, they have the mild asthenia, they have the monoarthritis or the oligoarthritis. So they don't present like a classical rheumatoid arthritis in the initial first 1 year or the 2 years of the presentation. If you don't diagnose at this juncture, so definitely these people will have more than the 50% of the people will have the erosions and the joint narrowings. By 10 years, 50% of the young working patients are disabled. Death comes early because of the multiple causes. It's a multi-system disease. And compared to the general population, women lose 10 years, men lose 4 years of their beautiful lifespan. Lot of the infections are very common in the rheumatoid arthritis, so secondary infections. So what are all the secondary infections you know of? Either bacterial infections or viral infections or fungal infections or tuberculosis infections, fungal infections. They're all so common in the rheumatoid arthritis because of the poor immunity in them. They die much early because of the premature atherosclerosis and ischemic heart disease and heart failure and cardiomyopathies, conduction defects, arrhythmias. So these are all very common in the rheumatoid arthritis individuals. And obviously with the sepsis and early atherosclerosis, they die early because of the increased mortality rate and the morbidity. It's a chronic disease, it's a systemic disease, it is an autoimmune disease that involves the inflammation in the membrane lining of the joints and often affects the internal organs. So that is the reason rheumatoid arthritis is purely a physician disease. So don't be happy with the symptoms of the musculoskeletal system. So as a good physician, you should see whether the lungs are involved, whether the kidney is involved, when the heart is involved, etc. Because internal organ involvement is also so common in rheumatoid arthritis. They exhibit a chronic fluctuating course, the flares, remissions, up and downs, exacerbations, etc. They are very common in the rheumatoid arthritis. So that can result in the progressive joint destruction, deformity, disability, and death. See the picture here. It's a chronic disease characterized by the periods of flares and the remissions. So we are very happy if the person gets the remission. Even in the days of the remission, you definitely prescribe some element of the disease modifying rheumatology drug or a low dose of the steroid to keep this fellow to stay in remission for prolonged years. So otherwise, when the fellow is in the remission, if you stop giving the DMRDs or the low dose of the steroid, and definitely these people will enter into the flares. So the flares and the remissions are very common in the rheumatoid arthritis. As a good physician, you should maintain the remission for a prolonged years and should not invite the flares. The exact cause is not known. The multiple joints are usually involved here, but not always affected in a symmetrical pattern. Rheumatoid arthritis can affect the people of all ages. Damage to the joints can occur early and does not correlate with the severity of the symptoms. This is the very important point. So even though the patient is very symptomatic, sometimes the joint involvement is very mild. On the other hand, the joints involved very highly with the destruction and the disability, but still the patient is not having much symptoms. So symptoms and the disease severity is not directly related in rheumatoid arthritis. And as you all know, the rheumatoid factor, so it is positive in some individuals and it could be negative in some individuals. So don't think that rheumatoid factor should be positive in all the cases of the rheumatoid arthritis. So according to the rheumatoid factor positivity or the negativity, you can divide the rheumatoid arthritis into seropositive and seronegative. Seropositive, more aggressive, rheumatoid nodules, more aggressive, and seronegative is not that aggressive. It is an antibody that can be found in the blood of 80% of the people with rheumatoid arthritis, not in 100% of the population. See the joints here, the botonine deformity of the thumb, ulnar deviation of the metacarpophalangeal joints, swan neck deformity of the fingers, the distal interphalangeal joints, etc. So there is hyperextension, hyperflexion of these joints. We consider it as swan neck deformity or the botonary deformity. This chart also I showed you the last week. So this is the normal joint, and in the normal joints, so see the bone, not only the bone, the muscle, the bursa, the tendon, the synovial membrane, synovial fluid, joint capsule, cartilage. So these are all the part and parcel of the normal joint. See the osteoarthritis here. So osteoarthritis, the bone ends rub together, thinned cartilage. In the rheumatoid arthritis, the bony erosions, swollen inflamed synovial membrane. So the synovitis is the most common in rheumatoid arthritis, whereas the cartilage destruction is common in osteoarthritis. See the synovial membrane here in the rheumatoid arthritis, reddish. That means inflamed, erythematous, damaged, and the fluid in the synovial cavity will be reduced, and there will be a lot of destruction of the synovitis, etc. So that is the hallmark in the rheumatoid arthritis, and later the pannus will form. See the osteoarthritis, see the bone spurs, loose cartilage particles, severe cartilage destruction. So these are all seen in the osteoarthritis. Whereas in the rheumatoid arthritis, the inflamed joint capsule and the synovial membrane, loss of space in the synovial cavity, and cartilage destruction. So what causes rheumatoid arthritis? Exact cause is not known, but it is believed that the tendency to develop the rheumatoid arthritis may be genetically inherited. So some people, so the rheumatoid arthritis runs in the families. It is suspected that certain infections are the factors, like the certain viral infections, or maybe the post-COVID, etc. They in the environment may trigger the immune system to attack the body's own tissues, resulting in the inflammation in the various organs of the body, such as the lungs or the eyes, and also the skin. So sometimes the rheumatoid vasculitis is also common. Rheumatoid nodules are the common. And in the eyes, the different forms of the idiopathitis, uveitis, etc. And in the lungs, rheumatoid lung, maybe because of the rheumatoid, or maybe because of secondary to your methotrexate. So methotrexate lung is possible, and rheumatoid lung is also a possible. Environmental factors also seem to play some role in causing the rheumatoid arthritis. Scientists have reported that smoking tobacco increases the risk of the developing the rheumatoid arthritis. So these are the environmental factors. So we can't stop the viral infections, but definitely we can stop the tobacco smoking. So smoking is definitely a big aggravating factor, the environmental factor to cause rheumatoid arthritis in those people who are genetically predisposed. It appears to be multifactorial. So when you don't know the exact cause, and probably it is a multifactorial like your type 2 diabetes. It is considered an autoimmune disease in which the body loses its ability to distinguish between the synovial and the foreign tissue. What are the environmental factors? There are some infections or trauma. They trigger the development of the rheumatoid arthritis. Genetic markers, HLA-DR4 is associated with the triggering in the inflammatory process in the rheumatoid arthritis. Such markers, however, are not considered diagnostic because 30% of the people with HLA-DR4 never develop the rheumatoid arthritis. So don't think that 100% HLA-DR positivity, like your HLA-B27 in ankylosing spondylitis, or rheumatoid factor in rheumatoid arthritis. They are not present in 100% of the individuals. Antigen-dependent activation of the T lymphocytes that leads to the proliferation of the synovial lining, activation of the pro-inflammatory cells from the bone marrow, cytokine, protease secretion, and autoantibody productions. Anti-cyclinated proteins, anti-CCP antibodies, they are very important in rheumatoid arthritis. They are positive in the early rheumatoid arthritis before your rheumatoid factor positivity. So whenever you suspect the rheumatoid arthritis, you advise the rheumatoid factor, and if it turns to be a negative, so then you can go for the anti-CCP antibodies. So that could be positive before your rheumatoid factor positivity. Suppose if the patient gets the rheumatoid factor positivity, then there is no need to send the blood again for your anti-CCP antibodies. Tumor necrosis factor, and interleukins 1, 6, 8, etc. They propagate the inflammatory process, and agents found to alter these cytokines show the promise in reducing the pain and the deformity. I will show you a picture where your TNFs and interleukins will act in the causation of your rheumatoid arthritis. Inflamed synovium, it is a hallmark of the pathophysiology of the rheumatoid arthritis we see in the pictures. So how the synovium is involved, synovitis, etc. It proliferates abnormally, growing into the joint space and into the bone, forming a pannus. So that is a diagnostic of the rheumatoid arthritis because of the extensive destruction of your synovial proliferation. This pannus migrates to the articular cartilage until the subchondral bone, leading to the destruction of the cartilage, bone, tendons, and the blood vessels. So what are all the organs in and around your joint capsule? So you seen the muscles, you have seen the bursa, you have seen the tendons, you have seen the cartilage, you have seen the synovium. So these are all things will be destructed because of this pannus. So gender is very important in the causation of the rheumatoid arthritis. As I told you, this is very common in the females. So 3 times more common in the men's, but in my practice, I have seen at least 8 to 9 times more common in the females. So if you see 100 cases of the rheumatoid arthritis, mostly 60 to maybe 70 to 75 cases are the females, and maybe 15 to 20 people are the males. So in Andhra Pradesh, in Godavari districts, I feel that rheumatoid arthritis is more common in the females when compared to the men, and my figures are maybe 7 to 8 times more common in women when compared to the men. After the menopause, the frequency of the onset is similar between the sexes. So the estrogen is making more and more incidence of the rheumatoid arthritis in these individuals. The use of the oral contraceptive pill has shown no effect on the RA as previously thought, but it may delay the onset of the disease. The disease is familial with an increased incidence in the first degree relatives and in the twins. So monozygotic twins is at 15% and dizygotic twins 3.5. You need not remember all these figures, but it's very common it runs in the families, more common in the females. So this is very, very important for the physician point of view. See, treatment anyone can give, but the understanding of this disease and pathophysiology is very, very important for the physician point of view. If you understand the pathophysiology better in any disease, and I think you will be the best person to treat, whether you are a physician or you are a super specialist. So without the pathophysiology, it's very, very difficult to understand the disease process. What you mean by the autoimmune disorder? In which the immune system does not differentiate between healthy tissue and the harmful antigens. That's so simple in autoimmune disease. You are not able to distinguish between your own cells, your healthy cells, and the harmful antigens. So as a result, the body starts destroying the normal tissues. Here the main inflammation in the synovial membrane. So this inflammation leads to the destruction of the cartilage and tissues in and around the joints. In severe cases, this inflammation extends to the other joints, other tissues, and leads to the joint deformities. The body replaces the damaged tissue with a scar tissue, causing the normal spaces within the joints to become narrow and the bones to fuse together. So this is the inflammation in the rheumatoid arthritis. So the immune system is a complex network of the checks and the balances, designed to discriminate the self from the non-self tissues. It helps rid of the body of the infectious agents, tumor cells, and products associated with the breakdown of cells. In RA, this system no longer can differentiate self from the non-self tissues and attacks the synovial tissue and other connective tissue. The same thing happens in almost all the autoimmune diseases. So the differentiation point will be lost, whether that is self or foreign antigens. So this is the beautiful slide. Shows you your hereditary predisposition and your environmental factors. So they activate the CD4 T cells. So these CD4 T cells, they act on the three ways. One is endothelial activation, macrophage activation, and the beta cell activation. So beta cell activation, so they form the rheumatoid factors, immune complexes, and these immune complexes destruct the bone and the cartilage. Your endothelial activation, the recruitment of the inflammatory cells. So because of this endothelial activation, the pro-inflammatory cells will there. So they also destruct. In the macrophage activation, so causing the chondrocytes, osteoblasts, and osteoclasts, again there will be the destruction of the bone and the cartilage. So finally, the bone and cartilage is destructed because of the B cell activation, macrophage activation, or endothelial activation. All these are because of the activation of your CD4 cells, because of the combination of your hereditary predisposition, your genetical factors, and environmental factors like some viruses, etc. or tobacco smoking. Same picture here. So some unknown antigen, the first one. So that attacks the CD4 T cells. So these CD4 T cells, the endothelial activation, macrophage activation, and beta cell activation. So the beta cell activation, finally the rheumatoid factor formation, immune complexes, etc., destruction, PANAS formation. Same thing, endothelial activation, they cause the accumulation of inflammatory cells. Again the PANAS formation. And the macrophage activation, so they cause the fibroblasts, chondrocytes, and synovial cells, etc. So definitely the destruction. So in the rheumatoid arthritis, the most important cell to be activated first is the CD4 T cells. So the CD4 T cells, finally they cause the PANAS formation, the destruction through the endothelial activation or the macrophage activation or the beta cell activation. So this is the worst part of the rheumatoid arthritis. So that PANAS formation. So the immune system attacks the proteins in the joints. Then the synovium will become the thickened, inflamed, and influx of the different immune cells. So these immune cells, combination of these immune cells is the PANAS formation, and that keeps on destructing the joint capsule. The genetic predisposition is a family history, certain ethnic populations, and especially the Godavari disease, they are more prone for the rheumatoid arthritis. A genetic marker HLA-DR4 is positive in nearly 50 to 60% of the population. Some viruses, some bacteria, some food allergies. Role of the hormones, especially estrogen, and then the immune system. So these are the predisposing factors or the environmental factors which act on the genetically predisposed individuals. So this is the clinical course of the rheumatoid arthritis. See the self-limited, very lucky people, 5 to 20% of the individuals. I think that only 5 to 10% is the self-limiting. Lot of the people with rheumatoid arthritis, so they develop the disease, either the mild or moderate or severe. Unfortunately, 60 to 80% of the people they present with severe rheumatoid arthritis. So self-limiting is possible in nearly the 5 to 10% of the individuals. Minimally progressive, maybe 5 to 10% or 15%. Moderately progressive, maybe 15 to 20%. And severe and aggressive is nearly 60 to 90%. So for this reason, we should learn much about the rheumatoid arthritis. So you are the right persons to diagnose the rheumatoid arthritis, to know the different organs are involved or the net is a multi-system disease, see the other organs in the body, and finally you are the right person to prescribe the disease-modifying rheumatology drugs or the biologicals. Because it's a progressive and a type 3 disease is seen in about 60 to 90% of the individuals. Maybe your father or mother, maybe your aunts, maybe your kith and kin, most important persons in your life, they must be having the rheumatoid arthritis. All these years they are getting some NSAIDs or some steroids, etc., without the proper diagnosis. And after 5 years or 10 years, they present with your ulnar deviation, with your bottom presentation, swan neck deformities, etc. Then your classic diagnosis is rheumatoid arthritis. But days have gone. Nothing can be done at that juncture. So as a good clinician, as a good physician, so you should diagnose the rheumatoid arthritis in the early days so that you can avoid this progressive disease and destructive disease. The pain in the affected joints aggravated by the movement is the most common symptom. Morning stiffness more than the 1 hour. Joints involved. See all the joints involved here. Mostly the small joints of the hands except the distal interphalangeal joints. In the same way, joints in the feet, wrist, ankle, elbow, shoulder. So these are all the very common joints involved here. But very rarely it involves the thoracic spine, lumbar spine. Very rarely it involves the hip joints and the distal interphalangeal joints. So these are the joints are spared in the rheumatoid arthritis, not the cervical joints. In the C1 and C2 may be involved in the rheumatoid arthritis. So in elderly individuals, when they are posted for the surgery, so general anesthesia, it's very ideal to tell to the anesthetist that this patient is a known case of the rheumatoid arthritis. So these are the involvement of the joints. So metacarpophalangeal and proximal interphalangeal joints, nearly in the 90% of the population. Not the distal interphalangeal joints. So distal is very common in psoriatic arthritis and osteoarthritis. Knees, ankles and the wrists, nearly 80% of the population. Shoulders in the 60% of the population. Elbows in the 50% of the population. Acromioclavicular and subcutaneous joints, etc., 30%. Okay. So in most of our people, they present with all these joints involvement. So very little can be done if the more and more joints are involved in the rheumatoid arthritis. So don't forget the cervical spine. Instability of the cervical spine can lead to the cord compression, quadriplegia. So it's a very important. So don't forget the cervical spine. Thoracolumbar, sacroiliac and distal joints are we cannot say the not involved, because in medicine it is not like a mathematics. Anything can happen in science, especially the medical science. But in my practice, usually they are not involved. Usually they are not involved. See the hands, wrists and the shoulders, very commonly involved. So different stages with rheumatoid arthritis. So the distal, proximal, metacarpophalangeal joints, wrist. This is a very, very important. Hand examination in rheumatoid arthritis is an art. So you should examine the hand in all the rheumatoid arthritis individuals, all the joints, whether the distal front joints, proximal, metacarpo, wrists, etc. So early is very, very important. What you mean by the early? Early morning stiffness, ask them early morning stiffness, how much it is? Is it half an hour, 1 hour, 1.5 hours, 2 hours, 3 hours, etc. Aching and throbbing joint pains and the duration of these pains. Redness or warm at the swollen joints, that is R, early, EAR-LY. And L, lasting the symptoms beyond the 6 weeks. 6 weeks means chronicity. So any arthritis occurring beyond the 6 weeks is a chronic arthritis. And hands and the feet are affected very commonly. So that is the early involvement of your rheumatoid arthritis. So let us see one case. A 26-year-old woman from Rajahmundry presents with a 4-week history of the swelling and tenderness of all the metacarpophalangeal joints, proximal interphalangeal joints and metatarsophalangeal joints of the feet. See, age is 26, place is Rajahmundry, history is 4 weeks history. Involvement of the hand and the feet, MCP and the PIP, not the DIP. Confirmed on the physical examination. No other stigmata on the examination. Her labs are remarkable for a ESR of 35, but a negative rheumatoid factor, negative CCP and negative ANA. So RA factor negative, anti-CCP negative, ANA negative, ESR is just 35. Okay. And the hand and the feet x-rays are the normal. Even the x-rays are also the normal. Her most likely diagnosis is, so she presents to the medicine department of GSL Medical College with a lot of the faith in you. So what are the correct diagnosis here? Is it lupus? Is it RA? Is it psoriatic? Is it fibromyalgia? See, anti-CCP is negative, RA is negative, X-rays are the normal. What is your diagnosis? Good, rheumatoid arthritis. See, rheumatology is mostly with history alone, you should come to a reasonable diagnosis. 80 to 85% you diagnose by the history, and only 5 to 10% your examination, and your lab will support only 5% of the cases. So it looks like rheumatoid arthritis. Even though RA factor is negative, even though the CCP is negative, even though ANA is negative, even your X-rays are the normal. Okay, even though the patient is not a multi-system disease, only the hands and the feet are involved. But here the age is important, the gender is important, the joint involvement is important. So then your reasonable diagnosis is rheumatoid arthritis. So that is the beauty of a good clinician. If you diagnose rheumatoid arthritis at this juncture, and definitely even if she happens to be, even if in her 80th birthday or 85th birthday, no internal organ will be involved in her. Because you are diagnosed with rheumatoid arthritis, so you are prescribing DMRTs, not your NASIRs or the steroids. So compulsory, what are the drugs of choice in rheumatoid arthritis? Disease modifying rheumatology drugs. Either your sulfasalazine or leflunomide or methotrexate or cyclosporine or azathioprine or cyclophosphamide, etc., etc., etc. So you are supposed to write DMRTs from the day one of the diagnosis of the rheumatoid arthritis, and obviously this patient will have very, very good not only symptomatic relief but also not the involvement of the internal organs, not extension of the disease. So that is the beauty of this case. Even though the investigations are the normal, X-rays are the normal, still your diagnosis must be a rheumatoid arthritis in this according to the history of the patient. See, the symptoms more than the 6 weeks duration often last the remainder of the patient's life. It's an inflammatory synovitis, a palpable synovial swelling, morning stiffness more than the 1 hour, and fatigue. Symmetrical and polyarticular typically involves the wrist, MCP, and the PIP. Typically spares the certain joints like thoracolumbar spine and the distal rectum joints. May have the nodules. This is a very important point on the rheumatoid arthritis. You see the rheumatoid nodules. Here the rheumatic nodules also. In rheumatic fever also you will have the nodules. But they are the tender. But here they are not the tender. 45% positive in the first 6 months. 85% positive with established disease. Not specific for RA. High titer early is a very bad sign. So the rheumatoid nodule positivity is a bad sign. Is an aggressive disease. Suppose if you are using the one DMRD in this patient, suppose you find the subcutaneous nodules, that is the time to upgrade the DMRDs. So you use a combination of the DMRDs because the presence of the subcutaneous nodules is a bad sign. It's a progressive disease and an aggressive disease. Marginal erosions and the joint space narrowing and the X-rays also will be seen in some cases. So this is the criteria. What is ACR? American College of Rheumatology. So 87. So they have the 7 points are there. 7 criteria points are there. One is morning stiffness more than 1 hour. That is the one criteria. Arthritis of the 3 joints. Your right or left hand, proximal, metacarpophalangeal joints, wrist, elbow, knee, ankle, and metatarsophalangeal joints. And third one is arthritis of the hand joints. Symmetric arthritis, nodules formation, positive rheumatoid factor, and X-ray changes. So these are the different 7 criteria are there. You must have 4 criteria to meet the diagnosis of the rheumatoid arthritis. Okay. So out of them, how many are the clinical? First 5 are the clinical. 6th is the positive rheumatoid factor and 7th is the X-ray changes. So without the lab, without the X-ray, you can diagnose the rheumatoid arthritis on clinical examination alone. With your history and clinical examination, you can diagnose the rheumatoid arthritis because you just need 4. Suppose if the patient morning stiffness is more than 1 hour, yes. Arthritis is there for more than 3 joints, yes. Symmetrical arthritis, yes, both right and the left. And then hand joints are involved, yes. And they have the nodules also. So definitely your clinical diagnosis is rheumatoid arthritis because you have the 5 points. And they get the RF positivity. Okay, fine. And you take an X-ray. So they shows the erosions, etc. So that is also good. So without the erosions, without the rheumatoid factor positivity, so you can still diagnose the rheumatoid arthritis according to this criteria. This is ACR criteria 87. But here one thing is very clear. On 1 to 4 points, they must be present for more than 6 weeks. That is very important to diagnose rheumatoid arthritis. It is not an acute arthritis, it is a chronic arthritis. So more than the 6 weeks is very important. Suppose all these there for the 10 days or the 15 days. So most probably you are not dealing a case of rheumatoid arthritis. Diagnosis and clinical evaluation. So again, in 2010, so this is the 1987. Okay, before your birth. So here the 2010. Okay, when you are the kids. EULAR, that is European League Against the Rheumatism, established a score-based algorithm criteria aimed at diagnosis before the joint damage occurs. Before the joint damage, you should diagnose the disease. Otherwise, after the damage, if you diagnose the diagnosis, so definitely very little can be done. So this criteria. So this criteria already wrist damage is there. Already nodules are there. It's a symmetric arthritis. A lot of the joints are involved. More than the 6 weeks duration. So even though if you diagnose the rheumatoid arthritis with this criteria, very little can be done to this patient. But according to this criteria, before the joint damage occurs. So how? Joint involvement, number and location of the involved joints. Serology, they have given a lot of importance to serology. Okay, rheumatoid factor and anti-CCP antibodies. Acute phase reactants like your ESR or CRP. And what is the duration of the symptoms? So this is the good criteria. This is the 2010 ACR, so American College as well as the European League against the rheumatism. The diagnostic criteria, joint involvements. One large joint, 0 points. So rheumatoid arthritis is mostly a small joint disease, not a large joint disease. 2 to 10 large joints, give 1 point. Sometimes it can occur, it can cause knee, or maybe the ankle, or maybe the wrist and elbow. So that is also possible. So 1. But 1 to 3 small joints, plus or minus large joints, you give the 3 points. More than the 10 joints, both the small as well as the large joints, you give the 5 points. So small joint involvement, you will get high points. Where the large joint involvement, you get the few marks. Then coming to the serology. Negative rheumatoid factor, negative anti-CCP, so obviously 0 points. Low positive rheumatoid factor and low positive anti-CCP. So they are just positive, but the low titers. So you give the 2 points. But very high titers of your rheumatoid factor and also the anti-CCP, you give 3 points. ESR and the CRP, they are the normal, 0, abnormal, elevated ESR, elevated CRP, you give 1 point. And the duration of the symptoms, less than the 6 weeks, no point, more than the 6 weeks, 1 point. And you take all these points. So for patients with at least one joint with a definite clinical sign of it is not better explained by another disease. Rule out psoriatic, viral, gouty, lupus, more than the 6 out of the 10 is a definite rheumatoid arthritis. So this is the recent criteria, 2010. Earlier criteria 87 is the ACR criteria. This is both ACR and ULR. There 7 points, here the 10 points, here the 6 out of the 10, there 4 out of the 7. Okay, so it is found in rheumatoid factors found in 60% of the patients with rheumatoid arthritis. As many as 5% of the healthy individuals will have the elevated titers of the rheumatoid factor. So you never treat the laboratory investigations. You don't treat the investigations, you treat the person. So some people will have the RA factor positivity. That doesn't mean that they need DMRDs, etc., etc. Because 5% of the normal individuals also can have a positive rheumatoid factor. If initially negative, the test can be repeated in 6 to 12 months. Rheumatoid factor is not an accurate measure of the disease progression. I told you that. High titers of the rheumatoid arthritis, the patient may be asymptomatic at the low disease. On the other hand, a low titers of the rheumatoid factor, but the patient is very symptomatic and aggressive. ESR and CRP, they are the markers of the inflammation. They are usually elevated in the patient with rheumatoid arthritis. They can also help indicate the activity of the disease, but they do not indicate the disease severity. Anti-CCP found in most patients with RA and are useful in predicting the erosive disease. See the X-ray changes. Extent of the bone erosions, cartilage loss, destruction of the joints, narrowing of the joints, okay, ulnar deviation of the joints. So these are all because of the proliferative pannus formation inside the synovial membranes. So how is this diagnosed by this juncture? So I told you that history is very important, examination is important, and you may write rheumatoid factor and the anti-CCP, the positive, you have more marks, negative, 0 marks, X-rays, erosions, narrowings, you have the marks, normal in some cases, and if the patient can affordable, so even MRI also is very useful because MRI will pick up the bony lesions much early than the X-rays. Anti-CCP will be more positive in the early days than your rheumatoid factor. So those people who can afford the patient presence in the early stages of the disease, so when you are in a doubt after the clinical examination, so you can give the anti-CCP and directly MRI of the hands to know any bony erosions, etc. It is an established disease. Once the nodules are there, so definitely even X-ray is also sufficient. What are the signs and the symptoms here? The fatigue is a very, very common in rheumatoid arthritis individuals. They are always asthenic, fatigue, stiffness of the joints, especially the early morning stiffness, and after sitting a long period of the time. Not relieved by the pain, low grade fever and weakness, muscle pain and the pain with a prolonged sitting, Symmetrical affects the joints on both sides of the body. Rheumatoid nodules, deformity of your joints over the time, Raynaud's phenomenon, pain. So these are all the symptoms. So that depends on the organ involvement. If the patient is arthritic, so mostly the arthritic symptoms. If the patient lung is involved, you can have the dyspnea, you can have the cough, etc. Suppose if the heart is involved, you will have the dyspnea, you will have the chest pain, you have the arrhythmias, etc. Suppose if the kidney is involved, then you can have the hematuria, you can have the proteinuria, and then the urea creatinine elevation, uremic symptoms, etc. So as it is a multi-system disease, so my suggestion to all of you is, you ask the arthritis symptoms, but not neglect the internal organs also. So you please ask some questions about the internal organ involvement. Clinical presentation, initial presentation may take the several forms, sometimes an acute onset of the polyarthritis, less than the 6 weeks duration, episodic onset, a persistent single joint arthritis, a persistent non-articular symptoms, extra-articular disease. Some people, they present only with the extra-articular diseases. Now the hands. This is a very, very important point, hand involvement in rheumatoid arthritis. The signs of disease often found in the hands early in the course of the rheumatoid arthritis. Even if the patient is not giving a direct information about the hand involvement, suppose if you are thinking that it could be a case of the rheumatoid arthritis, you please ask the patient, Emma Lakshmi garu, meeku hands involvement unda leda? Hands perfect ga normal ga unnaya, mee problem vachinappu nunchi లేదా హ్యాండ్స్ లో మీకు ఏమైనా అబ్నార్మాలిటీ అని కనిపిస్తుంది అంటే అవునంటే దెన్ దే రివీల్ దట్. సో మార్నింగ్ టైం నాకు కొంచెం ఇబ్బంది అవుతుంది లేచిన వెంటనే, సో బ్రష్ చేయడానికి కొంచెం ఇబ్బంది అవుతుంది, లేకపోతే కాఫీ పెట్టడానికి ఇబ్బంది అవుతుంది, దెన్ దే రివీల్ దోస్ థింగ్స్ అన్లెస్ యూ పోక్ దట్. సో బ్రాడ్ గా వాళ్ళు నాకు ఈజీ ఫెటిగబిలిటీ లేదా వీక్నెస్ లేదా మార్నింగ్ అది కొంచెం స్టిఫ్నెస్ ఇలా అని చెప్తా ఉంటారు. సో దే డిడెంట్ రివీల్ ద bad points of the hand involvement. So if you ask a leading question about the hand involvement, then they tell all these things. So that is the beauty of the, so what brain doesn't know, eyes will not see. So you should know everything about the rheumatoid arthritis, then you keep on asking the different questions. So then the patient will reveal the answers, and finally your diagnosis is a pakka diagnosis of the rheumatoid arthritis. Even though RF was negativity, even though the X-rays are negative, even though MRI is negative, even though anti-CSP is negative, you are damn sure that you are dealing a case of rheumatoid arthritis. So that is the beauty of the history and the clinical examination. So the medicine is a combination of the art and the science, very 100% true in these rheumatoid arthritis, in this rheumatology practice. So symmetrical effusions and the soft tissue swelling around the MCP and the proximal interphalangeal joints. DF involvement in the disease, later in the disease. Earlier I told you that DF involvement will not be seen, not seen, etc. But in the latter disease, maybe the extensive disease, maybe after 15 years, 20 years, 30 years of the rheumatoid life, then the proximal distal interphalangeal joints also will be involved. Joints are tender to the touch with a restricted range of the movement. Suppose if you touch the wrist, so then they will wince it. So that they feel the tenderness. Otherwise, they didn't reveal the history of any tenderness over the hands. So in the same way, if you palpate the metacarpophalangeal joints or the proximal interphalangeal joints, this is a very, very important. You have to touch the patient. You have to see whether the patient is having a tenderness over the wrist, over the metacarpophalangeal joints, over the proximal interphalangeal joints. So they are tender to the touch. Palmar erythema may be present in some individuals. Thickening of the flexor tendons or the carpal tunnel syndrome, etc. That could be also positive in some individuals. Nodules, yes, on the dorsal aspect of the hands, these are very common, and also here they are very common in the nodules. And nodules may cause tendon rupture, and then the ulnar deviation, swan neck deformity, butt neck deformity. So these are all at the latter stages. So these are all the hands involvement is a very, very important. Other physical signs, reduced grip strength. So grip strength is also reduced, not the 100%, maybe 80%, maybe 70%. Whole hand may be swollen with a pitting edema over the dorsum. So because of the erythematous, because of the inflamed synovial membranes, because of the extensive synovitis, so the hand is swollen. Range of the movement of the involved joints is restricted. So it depends on this. Suppose some people will have these 3 joints involvement, then this is a restriction of these joints. But this is the normal. So some people will have all the 5 joints involvement, then there is a 5 joints restriction of the movements. Suppose the last two joints are involved. These are the free. So then they're free, but this is the restriction is there. Tenderness is there. Okay. So this you have to see this patient. So characteristic joint deformities appear in more established RA. Ulnar deviation of the ulnar drift is very common. Swan neck or butt neck deformities of the fingers. Bowstring sign. What is bowstring sign? There is a prominence of the tendons in the extensor compartment of the hand. So this is the flexor compartment, this is the extensor compartment. So in the extensor compartment, you can see the beautifully see the tendons. So elongated tendons. So that is because of the tendinitis. Because of this your bursitis. Because of your myelitis. So these are all the very common. So that is bowstring sign. The nails and the fingertips also examined. So the nails abnormalities there in the psoriatic arthritis. So some people have the combination of the psoriatic arthritis and rheumatoid arthritis. Don't think that psoriatic arthritis is totally unique disease and rheumatoid arthritis is unique. So some people they might be having the combination of the rheumatoid arthritis and also the psoriatic arthritis. Okay. So examine the nails, examine the distal interphalangeal joints also. So should be examined in every patient for evidence of the distal infarct. So this is also very important. Fingertips. So the maybe the infarct, rheumatoid infarct, rheumatoid vasculitis. So have you seen the infarcts in the distals, digits, infarct, self-destruction of the fingers? So these are the very common in systemic sclerosis. Systemic sclerosis. So same thing happens in the rheumatoid arthritis also. So I will show the beautiful picture. So how you see the distal infarcts. So the risks are common in what? Loss of extension early in the disease. The flexion is common, but extension is, there is a restriction. Late changes due to the erosive damage. Subluxation, the radial drift of the corpus. Tendon rupture can also occur at the wrist. Carpal tunnel syndrome in about 4 to 5% of the cases. Then the elbows. Frequently affected in the elbows. Loss of the extension, so the fixed flexion. In the wrist also the flexion. Whereas the extension is painful, here also extension is painful. Effusion and synovitis in the elbow joints. Compressive neuropathy of the ulnar nerve. Olecranon bursitis is also common. Destruction of the joint may occur. Most common site for subcutaneous rheumatoid nodules. So for nodules, the most common site is in the elbows. Then the shoulders. Involved later in the disease, late in the disease, a painful restriction of the movement resembling capsulitis, like your headitis or your shoulder arthritis, like in periarthritis of the shoulder, diabetes. So you will have a restriction of your shoulder movements. Rotator cuff injury is very common and effusions relatively rare. So that's how we have to see the rheumatoid arthritis patient. So about the hands, about the vasculitis in the distal pulps, and then the wrist joint, elbow joint, shoulder joint. So there is the flexion, the extension is very painful, and nodules over the elbows. So this is how we have to examine upper limb in rheumatoid arthritis. Now the lower limb. The foot involvement is common in the early disease, like your hands. Tenderness of the metatarsophalangeal joints may be marked. Lateral drift of the toes and the plantar subluxation of the metatarsal heads. Involvement of the teres and the associated tendon sheaths is also common. Heel pain may be associated with the retrocalcaneal bursitis. See in rheumatoid arthritis. And sometimes I am saying the bursitis, sometimes I am saying the tendinitis. See, these are very common in rheumatoid arthritis. Not only your synovial membrane, synovitis. In some cases you can see the bursitis, in some cases you can see the tendinitis also. Diffuse swelling around the tibio-talar joints. Now the knee joint. Synovial thickening, effusion is very common. Restriction of the movement, particularly flexion. Ligamentous laxity leading to the deformities and the quadriceps atrophy and popliteal cysts. So almost looks like your osteoarthritis of the knee joints. But this rheumatoid arthritis, osteoarthritis may be exaggerated or secondary osteoarthritis is also very common in rheumatoid arthritis. So it is very difficult to differentiate between the rheumatoid arthritis causing knee destruction or osteoarthritis causing the knee destruction. So then you will have an MRI of these joints. So concentrate on the cartilage, concentrate on the synovial membrane. The synovial membrane destruction is more in case of the rheumatoid arthritis. Your cartilage destruction is more, there is a new bone formation, your osteophytes or cartilage breakdown. So then it's a more of osteoarthritis. Sometimes in a chronic patient, maybe 50-year-old female with a rheumatoid arthritis of the last 30 years. So then complaining of the knee pains. So it could be both combination of the rheumatoid arthritis and osteoarthritis. So you act accordingly. So only total knee replacement is not sufficient in those population, because total knee replacement for your osteoarthritis of the knee. But whatever the rheumatoid association, there you need to use DMRTs or biologicals or steroids, etc. is very important. Chudamma, charging. The hips occurs only in the well-established disease. Pain in the groin, thigh, low back are referred to the knees understanding, restriction of the movement. So the hips also you have to examine. But hip involvement in rheumatoid arthritis is very, very rare. Axial skeleton. So that is our spine. Involvement is also very rare in rheumatoid arthritis except your cervical spine. So cervical spine joints, most clinical important joints, painful stiff neck with restricted movement on the examination. Radicular pain at the C1 and the C2, compression also can occur. Trichoarachnoid joint, 30% have the involvement of this joint, hoarseness and inspiratory stridor. Now the systemic and non-articular manifestations. So osteopenia, osteoporosis is a very common in rheumatoid arthritis. So as I told you that this is a disease of the women, especially in the post-menopausal period, so the osteoporosis is very common. So if it happens to be a known case of the rheumatoid arthritis, this osteoporosis is multiplied. So muscle weakness, so myalgia is very common. Skin diseases, eye involvement, lung disease, cardiac disease. See the beauty of the internal medicine. So in all the rheumatoid arthritis patients, after your skeletal examination, MSK examination, you see the osteoporosis, you see the muscle, you see the skin, you see the eye, you see the lung, cardiac, kidney, vascular involvement, Sjogren's, Felties, nervous system, hematological abnormalities like anemia, thrombocytopenia, etc. So all these things can be seen only by you people. So physician is the captain to see all these conditions, all these involvements. Now what about the extraarticular manifestations? They present in about 30 to 40% of the individuals. Very good number. It is not just like 1 to 5%. 30 to 40% of the people will have extraarticular manifestations. May occur prior to the arthritis. That is the one thing very clear. Sometimes it occurs prior to the arthritis. They may present like hematological abnormality. So they may present with a neurological abnormality or a renal abnormality or a pulmonary abnormality. But still it could be a case of rheumatoid arthritis. So like your psoriatic arthritis, sometimes most of the times 80% of the people they present the psoriasis, so the dermatology department. Later they present with the arthritis. Then they come to the physician or the rheumatologist for the proper management of the psoriatic arthritis. Sometimes that they present like arthritis, psoriatic arthritis. You are not know whether it is a psoriatic arthritis or not because the nails are the normal, the skin is the normal, etc., etc. But in due course, after 2 months or 3 months, 4 months, then they develop the psoriatic patch. So then your revised diagnosis is this is not your this arthritis because of the psoriatic arthritis. Here arthritis precedes the psoriatic dermatological lesion. The same thing happens in the rheumatoid arthritis also in some cases, not in all cases. 95% of the cases you will have the extraarticular manifestations only after the onset of your rheumatoid arthritis. Patients that are more likely to get are high titers of the rheumatoid arthritis and anti-CCP. When the rheumatoid factor is very high, when the anti-CCP factors are very high, then there are chances of getting the extraarticular manifestations. HLA-DR4 positivity, more chances of extraarticular manifestations. Male individuals, so male rheumatoid arthritis, more chances of extraarticular manifestations. Early onset disability, the history is only 2 years, the history is only 3 years, but now the patient is having the abnormal disabilities. So definitely it's an aggressive disease, so might be having extraarticular manifestations. Smoking, yes. Nodules, rheumatoid nodules, that also more in extraarticular manifestations. So now the constitutional symptoms, they are most common. Rheumatoid nodules in about 30% of the individuals. Hematological, normocytic normochromic anemia because of the chronic disease. Leukocytosis, sometimes a leukopenia. So the total count may be 15,000, sometimes 2,000. Thrombocytosis. Felties syndrome, so it's a combination of rheumatoid arthritis, splenomegaly and neutropenia. So splenomegaly, neutropenia and rheumatoid arthritis. Here the subcutaneous nodules are there. So it is called as nodular rheumatoid arthritis. That is Felties disease. Respiratory, you will have the pleural effusion, pneumonitis, pleuropulmonary nodules, and interstitial lung disease. So here the respiratory involvement. In CVS, pericarditis, pericardial effusions, cardiomyopathy, and premature atherosclerosis, IHD, etc. Rheumatoid vasculitis, myelonitis multiplex, cutaneous ulceration, distal gangrene, and visceral infarct. CNS, neuropathies, peripheral neuropathy, cord compression from atlantoaxial or mid-cervical spinal subluxation, entrapment neuropathies like your carpal tunnel syndromes, etc. Eye, keratoconjunctivitis sicca, Sjogren syndrome, episcleritis, scleritis, etc. Sometimes we get the cases from the ophthalmology friends saying that this patient is having episcleritis, scleritis. So please rule out a systemic disease. Please rule out the autoimmune disease. So it could be a rheumatoid arthritis, it could be a lupus, it could be a systemic sclerosis. So you have to check all these diseases in those individuals. So sometimes, first they present with the ophthalmologist because of the redness of the eye, because of the grittiness in the eyes, because of the foreign body sensation, because of the watering of the eyes, etc. Then the ophthalmologist will diagnose the episcleritis or scleritis or iridocyclitis, etc. Then they refer to you. So these are the nodules. See, the most commonest site is the elbow, but mostly we see on the dorsum of the hand also. See the common sites for the rheumatoid nodules. So this is the proximal interphalangeal joints involvement. Swelling, synovial thickening, feels like a firm sponge. See the ulnar deviation and metacarpophalangeal joints involvement. On the right hand, all the metacarpophalangeal joints are involved here. On the left hand, fourth finger is involved, metacarpophalangeal joints. Across the room diagnosis, a prominent ulnar deviation in the right hand, MCP and PAP swellings in both the hands, synovitis of the left wrist. See the left wrist when compared to the right wrist, full and inflamed. See the joint swellings, see the subcutaneous nodules, etc. Joint deformity. Usually we see at this juncture. So we should not make our rheumatoid arthritis individuals to reach this stage. So you should diagnose at this juncture itself. See, these are the nodules. See the boggy swelling of the left hand. Rheumatoid arthritis. This is the Botanitis and swan neck deformity. So flexion of the proximal interphalangeal and extension of the DIP is the swan neck deformity. The reverse is the Botanitis deformity. So nodules. So this is the vasculitis. So the vasculitis is both in the upper picture and the lower picture. The upper picture in the early stages, the small dots, black dots are there in the thumb and also in the index finger. Okay, whereas here, middle finger and the ring finger, and you are seeing the abnormalities. So this is the rheumatoid vasculitis. So it's an internal organ disease. Here, what is the drug of choice at this juncture? We have to write the pulse therapy of cyclophosphamide. So cyclophosphamide maybe 500 mg or the 1 gram IV. So maybe for 3 days or the 5 days in a pulse therapy, so that you can correct the vasculitis. See the pleurisy. So the lung involvement. Okay. In the same way, some people will have the pericarditis or cardiomyopathies, etc. So differential diagnosis: acute viral polyarthritis, rubella, parvovirus, Hep B, occasionally associated with the presence of the rheumatoid factors, frequently associated with increased acute phase reactants, distinguished by the history, particularly of a rash, IgM antiviral antibodies, self-limited nature of the symptoms, connective tissue diseases and the sarcoidosis, difficult to distinguish from the arthritis of the lupus, Sjogren's and sarcoidosis. Hypermobility syndrome, fibromyalgias, reactive arthritis, psoriatic arthritis, crystalline arthritis like gout and the pseudo gout, osteoarthritis. So these are all the differential diagnoses. So when you are in a doubt in the early stages, so in the stages of your deformities, in the stages of your almost positivities are 4 out of the 7 or 6 out of the 10 criteria. So you diagnose the die itself is. But when you are in a doubt in the early stages, it could be post-viral, it could be post-hepatitis B, it could be psoriatic, or it could be etc. etc. So you know the differences. What are the investigations in the rheumatoid arthritis? Very few, like your complete blood picture. So total count. Suppose the patient is having the leukopenia and also having the splenomegaly. What is your diagnosis? Felties, leukopenia, splenomegaly, and rheumatoid arthritis. Nodular rheumatoid arthritis. So that is a Felties. Suppose the leukocytosis, anemia, high ESR. So typical rheumatoid arthritis. Okay. So then where ESR will be positive and your total count may be the negative positive. Sometimes the total count may be 20,000, 25,000 because of secondary infection. So these people are immunically, they are weak. So they attract the secondary infection. So because of the secondary infection, your total count is 20,000. Yesterday I have seen one fellow with fever, etc. with a total count 38,000. 38,000 total count. Polymorphs almost 85%. Lymphocytes 14% or 12%. Eosinophils maybe 1%. Monocytes maybe 1%. So that is the possible. So the patient is in sepsis. So you need to treat with very good antibiotics and immediately send the blood for the culture sensitivity, etc. and then treat accordingly. On the other hand, TLC maybe 8,000. So you need to try to some antibiotic there. Okay. So don't use a lot of the antibiotics in these patients. There is no role of antibiotic in rheumatoid arthritis, except patient presents with secondary infection. Okay. So acute phase reactants, rheumatoid factor positivity, anti-CCP antibodies, I have told you these things. So acute phase reactants. So the mild elevation, positive or negative. What are the negative factors? Albumin. So hypoalbuminemia is a bad. So the patient is having aggressive disease and very low immunity. And mild elevation, ceruloplasmin complement levels. Moderate elevation, your fibrinogen or ESR. And marked elevation, your CRP. So these are the rheumatoid factors. Antibodies to the FC portion of the immunoglobulin G. 75 to 80% of the patients have the RA factor positivity during the course of the disease. Useful for the prognosis. So antibodies that recognize the FC portion of the IgG, it can be IgM, IgG or IgA. 85% of the patients with RA over the first 2 years become the positive. And you diagnose the rheumatoid arthritis before the positivity of the rheumatoid factors. A negative RF may be repeated 4 to 6 monthly for the first 2 years of the disease, since some patients may take 18 to 24 months to become the seropositive. So this is the very important point. Even though the patient is the negative, don't think that this is not a case of the rheumatoid arthritis. From your minds, the RA factor positivity should be gone. There are some cases with RA factor negativity also. Still, their diagnosis rheumatoid arthritis. A prognostic value. Patients with high titers of the rheumatoid factor, in general, tend to have a poor prognosis and more extra-articular manifestations. When the rheumatoid factor is very high, so the two things are very clear. One is the patient is very aggressive disease, and these patients may have extra-articular manifestations. So see the liver, see the lung, see the kidney, etc., etc. What are the causes of the positive test rheumatoid factor? Not always a rheumatoid arthritis. Maybe 5% normal individuals. So these are all the diseases where your rheumatoid factor will be positive along with your rheumatoid arthritis. Could be Sjogren's, could be vasculitis, polyarthritis nodosa, sarcoidosis, lupus, cryoglobulinemia, CLD, some infections like tuberculosis, bacterial endocarditis, leprosy, syphilis, leishmaniasis, still they could be positive. Malignancies, and even the old age, 5% of women aged above the 60 years without any rheumatoid arthritis could be positive. Okay. So don't treat the tests, treat the person as a whole. Anti-CCP IgG against the synovial membrane peptides damaged via the inflammation. Here the sensitivity is 65%, specificity is 95%. Whereas the rheumatoid factor positivity, sensitivity may be 75%, but specificity is only 40 to 50% because a lot of the disease will be positive with the rheumatoid factor. So this anti-CCP is both diagnostic and the prognostic value. Predictive of the erosive disease. So the more the anti-CCP, more the disease severity, radiological progression, and poor functional outcomes. So when the anti-CCP levels are very high, so then definitely you should be very careful about this disease because this is going to be very aggressive, more extraarticular manifestations, and more symptomatic. So then you have to treat with a multiple DMRDs, maybe a biologicals also. So this is anti-CCP antibodies positivity. So other labs, thrombocytosis, leukocytosis, ANA may be positive in 30 to 40% of individuals. Inflammatory synovial fluid, hypoalbuminemia is a bad sign. So I stop here. Radiological, yes, after the radiological investigations we stop. We will move on to the treatment part in the next class. Periarticular osteopenia, uniform symmetric joint space narrowing, marginal subchondral erosions, joint subluxation, joint destruction, collapse. Ultrasound detects early soft tissue lesions. MRI has the greatest sensitivity to detect the synovites and the marrow changes. So MRI is very useful because now the MRI is available every place. So I always write the MRI in the early stage of the rheumatoid arthritis if I have a doubt. So I advise the anti-CCP antibodies and directly MRI to diagnose the RE or the not. Then if I am still in a doubt, I will tell to the patient that we will repeat this test after 6 weeks or the 2 months. Again or after the 6 months. So because still my doubt is rheumatoid arthritis. At this juncture, I may not write a combination of the DMRDs or I may not start the DMRDs, but you may need a DMRD or a combination in the near future. So don't think that this arthritis is only a self-limiting arthritis or a mild arthritis. It is going to be one of the major arthritis. Left untreated, so definitely a lot of the damage will be there. See the joints here, the third picture. So how damaged it is, ulnar portion. See the almost subluxation of the joints, destruction of the joints. See the C1 and the C2, hand joints. So this is the MRI, spikes, early changes. Okay. So what's the good news? So advancements in the diagnosis like anti-CCPs, MRIs, better treatments. Now we are very happy to treat the rheumatoid arthritis, very good drugs in our hand. And now advancing research in the stem cell, genetic based therapies, individual therapies are also possible.